I'll speak to you about radial access for peripheral interventions. No disclosures related to this presentation. The advantages of radial access are decreased access site complications, and this is one of the key points why radial access is being pushed worldwide. Certainly in the U.S., the radial access is slowly starting to catch on, and there's a geographic preference in the northeast portion of the United States. There are a large percentage of operators that use radial access, primarily for the coronary interventions. As you go further west, the use of radial access diminishes significantly. And so in my area, it's probably about a 24% use of radial access for coronary interventions and coronary procedures or diagnostic procedures. There's no need to use a closure device, so that saves you cost of the procedure. When you use radial access, patients can ambulate early, so patients that have trouble or difficulty laying flat are able to get up. They can be discharged early, and some people believe that the patient comfort is better with radial access. The advantage of radial access for peripheral intervention for patients that have aortoiliac occlusion, aortofem bypass, where the angulation is very acute and it makes it difficult, but not impossible, but certainly difficult to get access from the contralateral side. The hostile groin, meaning someone that has an infection, has had previous surgery, has scar tissue, or has a mass in the groin area. Anticoagulation for carotids with type 3 or bovine arch, and then access of the visceral arteries. Since the orientation of these arteries is usually in a downward projection, it's easier to access them from a radial approach. Peripheral interventions, usually femoral, ipsilateral, or contralateral is the predominant access. Antegrade femoral or popliteal and even transpedal alternatives exist. Radial is limited by a lack of available equipment, and I think the reason that we as peripheral operators have not used radial access more frequently is because we don't have the equipment that facilitates us to perform these procedures. So a 110 centimeter sheath will reach the iliac artery in most patients, but you can't really go much further than that. And most you also have to have the balloons and stents that are compatible with these longer devices. So it means that you have to have a very extensive inventory if you're going to do peripheral interventions from radial access. We prefer the left radial artery because it seems to be shorter distance and you don't have to cross all of the arch vessels when you work from the left radial artery. In your patient population, you may be able to actually do this from the right side of the table, which most of us are comfortable with working from, since we perform the majority of our procedures from the right side of the table. In my patient population, if I'm using left radial access, I'm on the left side of the table because I can't lean over or reach over most of these patients just because of their size. I have to work from the other side of the table. And the left carotid is probably best approach from using a femoral route. Sheaths and wires are now available that allow us to do procedures from the radial access. We need other technologies to follow. That means the other devices, apart from just the balloons and stents. And industry must develop 6 French compatible devices to facilitate doing these procedures. This is a diagram that just basically shows you sort of the typical lengths or what you would need to get to certain areas in the circulation. And you can see for the popliteal, you need 150 to 180 centimeters, for the average patient. So none of us really have that kind of inventory in our cath labs yet. Complications of transradial access, anatomic variation is found with failure to obtain access in about 25% of patients. The left subclavian artery coming off in an abnormal position is a reason to fail, usually with coronary procedures when that's being done from the right radial access. Spasm, radial artery occlusion, and radial artery perforation. With respect to spasm, there are a lot of different treatments for spasm, and you will read about all the different pharmacology you can use to try to treat the spasm. The best treatment for spasm is to avoid it. So when the patient has discomfort, when you're manipulating a catheter or a wire, you need to sedate that patient, because if you don't, they'll get into the vicious cycle with spasm, and when they have spasm, more often than not, you're going to have to abort the procedure. You won't be able to proceed. These are complications listed for radial access, and I think what's important is if you look in that sort of third column, you can see that inexperience is listed as one of the risk factors for having complications. So certainly you want to start with simple transradial cases and then advance to these more advanced forms of radial cases, including the peripheral interventions. This is a complication that you need to be aware of if you're going to be performing radial or transradial access. It's the sterile radial granuloma. Sort of looks like this. The image isn't projecting very well, but it's a granuloma that appears to be infected. Early on, these patients had biopsies. They got treated with antibiotics. They had a lot of different treatments, but it was related to the lubricant on the hydrophilic coating on the sheath, and it caused this sterile granuloma. It's something that usually is self-limited. Do not biopsy them. They do not heal well, and it takes a long time for them to heal if you try to biopsy it. Other complications include compartment syndrome, pseudoaneurysm, and radial artery occlusion. Interesting about radial artery occlusion, in a study that looked at patients that had radial artery occlusion, when they got sent home, about 50% of those arteries are open at 30 days. So with the collateral flow and with just time relief of the spasm and maybe some overlying or thrombus, those patients can recannulize their radial artery. Hopefully the technology will allow most peripheral interventions to be performed via the radial access. Right now we do have some sheaths that are available that are over 200 centimeters long, so we can do more procedures from a radial approach. Most of these radial accesses are 6 French. Usually when you go larger than 6 French, that prohibits you from doing a lot of patients. But what has happened is that they've designed catheters, or they've designed sheaths that have thin walls, so even with 6 French you can get devices that typically we would have had to use 7 or 8 French guiding catheters to use through that 6 French sheath. So the technology is evolving, but it's not ready for everywhere yet, and we need to push industry to make sure that they continue to develop these products. This is a case that hopefully will show what you see here is a sheath going across into the brachial artery. And when you pull the sheath back, this is what happens. So this artery has been perforated or avulsed. Now you would think that you have to operate on this or you have to do something dramatic. No, you can either just inflate a balloon or put the sheath back across, finish your procedure, and then when you're done with the procedure, most of the times hemostasis has been obtained. So the radial artery actually is very forgiving. You just have to recognize the complication and deal with it before you get the patient out of the angiography suite. So if they're bleeding, stop the bleeding. If you've ruptured or perforated, in general, you don't have to stent these. It's not like an iliac or a femoral artery where you may have to place a covered stent. Most of the times it's just treated with a balloon, or even just advancing the guide catheter or sheath across the area that's perforated, and it seals before the procedure's ended.